Good morning. I am Dr. Amit Mondal from All Indian Institute of Medical Sciences, New Delhi, India. I am presenting role of ultrasound in assessing tumor characteristics and locoregional spread in cervical cancer. Cervical cancer ranked fourth in incidence and mortality worldwide, and India accounts 25% of the burden. The International Federation of Gynecology and Obstetrics revised the staging system for carcinoma of the uterine cervix in 2018, which used imaging and pathology findings. MRI is the most suitable modality when available, but ultrasound has shown comparable results to MRI in many studies. Considering the cost effectiveness of ultrasound, we evaluated its use in cervical cancer staging in this study. The aims and objectives were to compare the accuracy of transrectal ultrasound and transvaginal ultrasound with MRI for tumor size and local extent, and to compare the accuracy of transabdominal ultrasound with MRI for pelvic and paraortic lymph nodes. We did a prospective interventional study with 59 cases. 39 were planned for primary chemoradiation and 20 underwent radical hysterectomy. We used the four modalities of imaging: TVS, transrectal ultrasound, transabdominal ultrasound, and MRI. In each case, before treatment allocation and assessed maximum tumor size, parametrial invasion, lymph node status. The mean age and BMI of the patient in the two groups were comparable. Majority were squamous cell carcinoma, adenocarcinoma, and neuroendocrine tumor, both constitute 3.4%. In primary chemoradiation group, the stages were 2B and 3C1 mostly, and in radical hysterectomy group, 1B2 and 1B3. TVS and transrectal ultrasound have a good agreement for maximum tumor size. Both have significant p-value. The sensitivity of TVS is 50%, whereas for transrectal ultrasound is 25% for detecting tumor size less than equal to 2 centimeter. Whereas for parametrial invasion, the sensitivity of TVS is 80%, whereas transrectal ultrasound is 70%. And MRI is accurate and had 100% sensitivity and specificity in determination of parametrial invasion, whereas transrectal ultrasound has good accuracy of 80%. But TVS did not perform better. Among 12 lymph nodes detected by MRI, transabdominal ultrasound detected only 3. And TAS did not detect any lymph node which were detected by MRI and were histopathologically positive. 5% cases performed by transrectal ultrasound has pain score greater than equal to 6 with tumor diameter mostly more than 3.5 centimeter. Whereas for TVS, those with more than 3.5 centimeter, the pain score was 6, but it was only 6.8%. Bleeding occurred with TVS in 50% of the cases. And 2 cases of parametrial invasion detected on histopathology were not detected on TVS, whereas 1 case was detected by clinical examination. So in our study, we found good agreement in measuring tumor size by TVS and TRUS, so both modalities can be used in absence of MRI. For parametrial invasion, TRUS did better, but TVS did not. So TRUS can be generalized for staging in absence of MRI facility. TVS has accuracy in determining tumor size, but its role in parametrial evaluation is less clear, so cannot be generalized. Moreover, TVS has bleeding complications. TRUS is also associated with pain, so adequate pain management is required. TAS can detect lymph nodes but cannot substitute MRI. So TRUS is more accurate than TVS in staging of cervical cancer, where MRI facility were lacking, and considering the cost effectiveness. As most of the gynecologists and radiologists were familiar with TVS than TRUS, so its use must be enhanced in low resource setting.